This is a warm welcome to all of us for joining the second session of Amidst web series. On this edition, we'll be discussing the topic, Sustaining Family Planning and Sexual Reproductive Health Services Delivery Amidst COVID. This session is featuring two eminent speakers, one from Amidst Nigeria and the other speaker from the Federal Ministry of Health. In the course of the session, we'll introduce them properly. But before we start, I'll quickly want to introduce Amidst Nigeria to us, and then we'll set the floor rolling for the second edition of Amidst web series. Amidst International Organization Nigeria envisions a nation in which every birth is wanted. Our mission is to empower Nigerians to have children by choice and not chance. We are part of the Amidst International Global Partnership spread across 37 countries. We established in Nigeria in 2009 as specialists in the delivery of quality sexual and reproductive health interventions. Since inception, Amidst has worked collaboratively with the government of Nigeria at all levels to redefine quality in sexual and reproductive health services, and with our donors and civil society to increase access to quality and affordable services, with focus on promoting universal access to contraception to every Nigerian requiring it. Our programs are implemented across the 36 states of this federation and the Federal Capital Territory, Abuja. Our services and mode of delivery are free from stigma and discrimination. They are non-judgmental, regardless of age, gender, location, background, and marital or economic status of the client. Our services are tailored to meet the needs of the client. We do not restrict our clients to a one-size-fits-all approach, but we keep our clients at the center of all of our interventions. We tailor services and approach to address the unique challenges of the clients. We do this by employing several channels of service delivery to ensure no one is left behind. Our channels include the Center Channel, a chain of Amidst owned and managed clinics presently in Abuja, Lagos, and Benin. We run a Blue Star healthcare network called the Social Franchise Channel, where we collaborate with privately owned healthcare facilities to widen access to services and strengthen standard of care. Through our outreach channel, we reach underserved populations in remote and hard-to-reach locations, providing integrated healthcare services free to clients. Our Amidst Ladies Channel is a community-based network of healthcare providers who deliver services door-to-door or from their own homes to women within their communities. As part of our collaborative efforts with government at all levels, we have a channel dedicated to public sector strengthening, through which we deliver all-inclusive capacity building, continuous party supervision, and competency assessment programs aimed at strengthening our public health system. Lastly, through our social marketing channel, we deliver lifestyle and life-saving products nationwide, aimed at providing quality reproductive health care to every Nigerian. Amidst Nigeria is committed to sustaining family planning and sexual reproductive health services delivery amidst COVID, hence the theme of this virtual learning event. We welcome you, and we hope that this will be a worthwhile experience for you. Right now, we'll go straight into calling up our speakers to take the center stage and speak on the different topics. As earlier said, our topic for today's session is Sustaining Family Planning and Sexual Reproductive Health Services Delivery Amidst COVID. Our first speaker will be Effium Young Effium, Country Director, Amidst International. Effium Young Effium is the Country Director of Amidst International Organization, Nigeria. He has over 20 years experience in the commercial and private sector business models and in running social business enterprise. He is skilled in using private sector business models to deliver social benefits. Effium has a culture of excellence and high impact results. He has varied experience working for reputable firms in pharmaceutical sales and marketing. business development, and healthcare consulting. Effium holds a bachelor's degree in pharmacy from the University of Ibadan and a master's degree in business administration from the University of Oxford. He is a graduate of the Senior Executive Program at Astrid University, Hawk International Business School. Please join me as we welcome Effium to give us the Maristo's perspective in responding to sexual reproductive health interventions during the COVID pandemic period.
Thank you, everyone, for joining. I want to start by specifically thanking the Association of Reproductive Health Journalists of Nigeria for partnering and making this happen. I want to thank the amiable Dr. Afolabi, the Director of Reproductive Health. Thank you so much, sir, for joining us with this. It's a privilege to be a speaker with you on this panel. I wanted to share, our perspective on sustaining family planning and sexual reproductive health services delivery in the midst of COVID. Which he had highlighted, Maristo's work trying and making sure we offer comprehensive sexual reproductive health services that will enable women we are strengthening channels where we work with different PHCs across the country. Our team, which are 33 right now across the country, and also our we call MS ladies who are in across states. We have 3 static clinics in Lagos, Abuja, and Edo, and we work with some additional clinics network across 15 states of Nigeria, including Kano and Kaduna. Unwavering, we believe in a world where every birth is wanted, and our mission is that children should be by choice. This we've upheld in Nigeria over the last 10 years. We have seen his impact from the index case in January. In February 27, and as at yesterday, we have over 15,000 confirmed cases. And I'm sad to say that we've lost just under 400 Nigerians, our fathers, mothers, and friends. With the infection being on the rise, the government started by implementing lockdown policies, and with the leadership of the NCDC and the Federal Ministry of Health, Nigeria have come to know about this disease, and we're constantly being informed. And right now we're in the era where government is losing controls and trying to get us back to our way of work and life. But we also know that with the demand of responding to this COVID has been and is constantly overwhelming our healthcare system. and of course, other service provision channels will be at risk or will become more challenging, and most especially the sexual reproductive health programs. There's a broader implication for this as it concerns the sexual, family planning and sexual reproductive health channels and services. If our learning from the containment Ebola response, for instance, with our Sierra Leone program, showed us anything, it was that people emerged from lockdown with reproductive health emergencies, ranging from unwanted pregnancies to sexual rights violations across the country. Women, of course, their inability to access service predisposes them to reproductive health risk, such as unwanted pregnancies and complication from STIs. Product logistics becomes also a challenge within this period. And of course, there are safety concerns that emanate from this lockdown and this pandemic, especially as it affects our healthcare providers. Right now, we all know that over 800 of them, from the last information from the government, the PTF, are already infected. So for us, we had to take a decision immediately to act, knowing all this. And from our experiences, we had to go into action immediately. Our response was rather very, very clear. We were very sure that we wanted to make sure that service delivery was not in any way hindered during this period. And our first response was to immediately set up an internal COVID response team with real-time response and having to track state-by-state situations and occurrences while taking guidance from the national, the NCDC, and of course the PTF. We had to immediately request for approval and passes for all our health workers across the states, and also from the federal Ministry of Health. And I want to say that for all the states we approached and the federal government, there was no hesitation to provide us this pass. It just really showed that there was a general understanding that reproductive health was an essential service in this period. I want to particularly thank Dr. Anna Askolo, who immediately responded and sent us a letter, and all the state FP coordinators and the primary public health departments that made it possible for us to get the letters to allow our essential workers move across locations and states. The next thing was for us to develop a guideline that really made sure we looked at the individual channel of operations and understand that we needed to standardize all our practice and care across board. And then based on the guidelines from the NCDC, we needed to immediately deploy personal protective equipment so all our frontline staff, our staff in the office, and also all our third-party providers. For us, safety was first, and having to deploy this, train them, constantly making sure they understand the importance of this, adhering to these standards and protocols was very, very essential, because for us, we needed to ensure their safety and also that of the client. And then the next step was to make sure we took stock of our minimum stock quantities across the state and make sure we immediately set together a plan to distribute supplies, to supply commodities and consumables across our program. We also went further to mainstream COVID prevention responses and message in all our mobilization and service deliveries channel. It was also important that in doing this, we tracked productivity of each team to ensure that we constantly maintain good value for operational investments made during this period. All our donors, and I want to thank the UK DFID, who did not cut any corners or restrict any services and make sure we're focused on with the right funding, even providing us and making sure that all our providers had PPE materials immediately this started. This response was very critical, and how we use this fund and make sure there was no wastage was also critical in our strategy. Specifically, we had to look at our channels response, and we also found out that all channels were not equal in how we needed to respond to it. So while if you look at our center specific channels activities, you will see like for our 3 centers, we had to immediately rethink our online engagement strategy because we were very sure that people were going to be at home. Social media was going to be very important, and our audience, we needed to reinforce with our clients and our population that our clinics were open. For our clinic staff, we needed to ensure there were vehicles to pick and drop them to be sure they were there on time, and in all their transportation needs, they maintained the right protocol. We started home delivery also for refilling of contraceptives, and in some cases, samples for testing across our labs. For critical staff that needed to come into the clinic where there was a challenge with transportation, we made sure that was in place. And of course, we had to use telemedicine, especially around consulting, to make sure only people that needed to come in to the clinic came in. For outreach, we needed to really, our focus in our outreach was really around 3 major pillars: proximity, productivity, and safety. These were our key concerns. So we needed to make sure our team were not going across state if they didn't need to. They were targeting far-flung areas within their particular state, and they were returning back home daily. We also had to include flexibility around their scheduling to make sure we're working with the local government reproductive health coordinators to make sure that people were ready and the right conditions were in place for the client and also for ourselves. For our private sector hospitals we supported or we're constantly supporting, the first consideration for all was to immediately make sure that we support the facilities to achieve the right protocols across the program, across their facilities. We also needed to make sure that there were cases where their clients might not be able to come to them. So we expanded on our in-reach procedures, that service delivery that let us take service closer to the people. So their coming to the facilities was really a short distance for them to travel. We noticed also that with our community-based healthcare workers, that we found out there was an increased need for their services. We made sure that they were also trained, supplied the right commodities, and we were tracking their progress daily through WhatsApp and ensuring that they were being coordinated and they were safe in all their process of reaching out and trying to get to the right people with their door-to-door services. Our public sector facilities were not left out. We also made sure that we support with the last mile delivery. We had the partners in charge of supply chain logistics were key in this, but also we made sure that stock was available at the facility. The FOMH under Dr. Flaby was very prompt in supporting us with commodities, and the state distribution system was also key to understand the need for us to get these products at this facility at the right time. And of course, we needed to make sure that data was not amiss in this channel. Social marketing was a bit tricky, but we had to support a system that allowed the wholesaler and retailers continue to provide, get their stock, and also support, make sure that commodities were available at their point of uptake. This was key because a lot of people, their first line of care for them were the centers, where the pharmacy and the PPMVs. Surrounding all this was our contact center, where we made sure we integrated confidential and non-judgmental professional advice for people that called in, and also give them the right referral as based on their location and their need. This was offered in English, Igbo, Yoruba, Hausa, and even Pidgin to make sure nobody was left behind. Of course, you will have expected we saw a lot of increase in calls within this period as people needed more guidance. So what was the result of all this? I think we were proud to say that all our service channel and all our facilities across the country continued to provide service across for everybody that were coming to our centers, and there was no breakdown in service within this time. We made sure we communicated effectively, and we were tracking this to see reporting rates, and it was good to see that the reporting rates were comparable before the pre-COVID period, and in some cases even improved. The output of this also were things we noticed was that clients' visit to our sites, facilities we support, actually increased by 22% within these last 3 months when we compare with the previous months. And interestingly, there was a deeper skew to permanent methods, implants, and IUD. IUD actually doubled within these 3 months period. Just to show you this graphically, just to see, if you see, the total client visits almost doubled. Implant was almost double within this period. And the permanent method also doubled. Of course, you can see post-abortion care and need with this period was also doubled. And these were interesting things to notice, and it also made us understand that there was really a need for services within this period. The next slide showed, you can see from the next slide, the data reporting within this this intra-COVID period. If you see, the Southwest was actually, we'll call the center point for this COVID, and there was a marginal improvement in reporting. The South-South still maintained a higher reporting rate. And it was interesting to see even the Northeast did not fall behind in reporting during this period. And the final graphic slide I will share with you. So the next point for us was around what was the impact of keeping these facilities opened within this period. Within the last 3 months, we have seen that persons across our different channels, just under 800,000 people attended to take up one service mix or the other. And if we put this into our impact 2, we can actually say that over just under 800,000 unintended pregnancies were averted were prevented within this period, which will have resulted to about just under 300,000 unsafe abortion. And we estimated that just under 4,000 maternal deaths were averted, with close to 20,000 child deaths prevented within this period. This, in a nutshell, is what I wanted to share with you. And I hope this also makes a case for us to continue to strengthen service delivery, even as we go into the easing period, and even as we begin to learn to live with the coronavirus. Thank you for listening, and I'm sorry if the internet has not been very good.
Thank you so much, Country Director, Mr. Effiong, for that great run-through of the intervention of Marie Stopes during the pre-COVID, intra-COVID period. Excellent performance, I must say. You've been able to take us through how Marie Stopes sustained intervention, how the organization set up an internal response team, how you were able to put up regulatory guidelines to guide the activities of the different channels of service provision, and the good collaboration between the government and Marie Stopes even during this period. You've also informed us of the specific channel activities that we had implemented to ensure that service provision were tailored to meet the needs of the clients, while ensuring that the guidelines provided by the NCDC was followed. You've also informed us of the excellent performance of the intervention, showing that there was value for money. It was not a waste to sustain intervention. However, client numbers increased, service uptake increased, and then the organization also ensured to protect clients and providers by implementing personal protective equipment was available to all providers and team members. So we'll open the floor right now for questions. We'll have 7 minutes to take questions for this particular presentation. You may feel free to raise your hand using the hand raise icon on the chat box on the platform, or type in your questions into the chat box. So the floor is now open for questions for Effiong. From the chat box, I can see more of commendation for the organization. Do we have questions?
Maybe just to join you, Ogechi, as usual, way back in school, when the lecturer or teacher teaches and then he says questions and nobody's coming up with questions, he would naturally have questions for the audience. So maybe it's a good time for us to put up the first poll, which of course revolves around a few questions that people should be able to respond to if they have followed the presentation by Effiong. And so I'll be launching the first poll and would request that attendees should please respond based on the answers that they have picked, having listened to Effiong in the last few minutes. Just 5 questions. Please choose the right answers as you believe they are. And then we would be looking through to see those who are raising their hands to ask questions, and we'll grant them permission to speak. Ogechi, I hope you can see the poll.
Yes, I can.
Okay, so the responses are coming through as well.
Yeah, they are flowing in.
Just to give everyone comfort, we won't send the scripts to the kids at home. So just be at liberty to choose what you think is the best answer. And we'll probably have Effiong confirm which ones are the right answers to the 5 questions.
Okay, so I have the first question from the chat box from Elizabeth Abimbola. She's saying, thank you, sir, for the comprehensive presentation while the lockdown was on. Could you tell us how you upheld social distancing? So, sir, Elizabeth is asking, how did Amidst uphold social distancing in our service provision and activities during the COVID period?
Thank you, Elizabeth. I think one of the major parts, one of the struggle with, it was easy to do this around the facilities, the static facilities where we had outlined spaces for people to stand and wait. We had people, that securities that also supported them in how to stand and wait for their turn. It was a bit difficult with the outreach points, if I'm being honest. And the process will be to work with the PHC team who set the standards for how they sit. Also was the temperature measuring procedures before they even get to sit, to try and using the infrastructure meter to see those people that probably had some indicative temperature that we could use to send them to the main clinicians or hospital people. And then we advise and also try to tell them how to stand. I think there was a video of 1 or 2 things where times when that was adhered to. But I think at the end of the day, that I don't think we can boastfully say there weren't challenges around that, especially in some facilities where we saw close to 100 women come out at a time to our outreach. Part of what we did was, of course, ensure everybody washed their hands and advise them on the protocol. Reality was a bit different, if we're being honest, but between our service providers and the clients, we ensured all the protocols were in place.
All right, thank you. We have about 4 people raising their hands. We'll admit Yinka Shokumbi to ask her question. So we'll be taking 3 voice questions and about 2 more chat questions before we move to the next session. So Yinka Shokumbi, you have the floor. Please ask your question. Okay, while we try to unmute Yinka, we have another question saying, did we encounter rape victims in the course of service provision? And if yes, how did we respond to that as Amidst?
There were no particular rape cases within this period. However, we are gradually integrating gender-based violence protocol across our outreach locations, points. And part of what we do as part of our counseling, and when this arises, is to also talk to these women, as the case may be, and then connect them to other more qualified partners in this field to support them and also guide them appropriately. I think one of the things we're beginning to now refocus on is really trying to make sure, one, that our contact center is best prepared to respond to calls as it relates to this. One of them is protecting the right evidence from the beginning of when this is reported, letting them know the importance of reporting early, and also trying to protect the evidence. There have been some work with other partners on training police. I know 2 weeks ago one held by other partners that are working in this space more. But it is always easier for us in states where the VAP Act of 2015 has been adopted. And I think for us is also trying to encourage a lot of states to adopt this VAT bill where the Violence Against Persons Provision Act, the Violence Against Persons Provision Act, Protection Act allows us to report this and follow through with it.
All right, thank you. So I'm unmuting Ijoma Okazu. She has her hand up. Please, Ijoma, ask your question.
I've also unmuted Yinka, so Yinka can go after Ijoma if you prefer. Yinka, if you can hear us, or
Ijoma, I can hear you.
Go ahead, please, with your question. Okay,
good morning. Good afternoon. Yinka Shokubi is my name, the National Secretary of the Network of Reproductive Health Journalists of Nigeria. Actually, I think we should just take away my question from the box, because when I couldn't, I had put it. I was going to ask, and I'm asking, during your data collation, in the period when you collated for Southwest, did you try to separate the states? We want to know if Lagos, Ogun, and Abuja were about the same time on lockdown by the federal government. We want to know what the incidences that you recorded for Southwest, how did it go by states? We want to focus on our own state, Lagos and Ogun, as well as the Federal Capital Territory for purposes of our own analysis. Did you do that? If you do, can we have the figures? Thank you.
Inka's question is around disaggregated data by state. She's asking if we have the state-specific data for Lagos and I think Ogun State, beyond the regional data that we have just presented.
On to specific data, you have the numbers off now to.
Okay. So Yinka, the state-specific data is not available right now, but we have that and we can share with you via chat or via mail. So we'll pull out the state-specific data for the states you have indicated, and we'll be able to provide that information to you. Would that be fine? All right, we'll go to the next question. That's from Ijoma Okazu. Ijoma, your mic is unmuted. Please proceed and ask your question. So it seems Ijoma is having a challenge asking her question. Let's proceed and have Dr. Ufoma's question.
First of all, I want to use this opportunity to thank the Network of Reproductive Health Journalists and the Federal Ministry of Health for collaborating with Mary Stopes to put this event together. One of the exciting things, what I love about this activity is the fact that reproductive health is put on the front burner. I heard them speak about the lessons from EVD, and my question pretty much would more be aligned to checking out what was the response of state governments, at the state and the local level. Did they see reproductive health or family planning services as an essential service at this time? Because for us in Sierra Leone, one of the things we learned from EVD was that with lockdown, increased sexual activities. In the Nigerian space, we are talking about only the gender-based violence and the other things about sexual harassment and rape that is going on. But how prepared, are we prepared for the baby boom that is emerging? What are the states doing? Are they very clear about what they need to do at this critical time? Because taking no action now and assuming that all is all well and activities will go on is preparing us for a big crisis, a big population explosion and boom in the face of so much that is needed to cater for reproductive health services. Thank you.
Thank you so much, Dr. Former. CD.
Thank you for for the question. I think some of that will sit when Dr. Afolabi, who is presenting next, answers that. But for Maristo, it's going to be the certainty around the fact that we'll continue our and also continue to make sure we expand our services as is allowed in the law, and all we need to do, and to give our women and men the confidence that we are there as a partner even as they come out of this.
All right, thank you so much, CD. We'll stop the questions for the first speaker right now, but please do type in your questions to the chat box and we'll be responding to it. And at the end of the two speakers' presentations, they will still be around to respond to some more questions. So right now, we'll go on to have the second speaker. Dr. Afolabi. Dr. Kayode Afolabi holds a bachelor's degree in medicine and surgery. He is a fellow of the West African College of Surgeons in obstetrics and gynecology. With over 30 years experience in the field of reproductive, maternal, newborn, child and adolescent health in Nigeria. He worked as consultant obstetrician and gynecologist at Adoyo Maternity Teaching Hospital and the University College Hospital, both in Ibadan, and served as Commissioner of Health to the Oyo State government. He is currently the Director in charge of Reproductive Health Division at the Federal Ministry of Health, where he provides leadership in sexual and reproductive health, system strengthening, government policy development and implementation, as well as humanitarian program management, aimed at improving the health of mothers, adolescents, and children under the age of 5 in Nigeria. Dr. Afolabi's strategic leadership and coordination of stakeholders has seen better coordination and guidance in management of government and donor resources for effective implementation of programs, improved performance management at state and national levels towards achieving reproductive health-related sustainable development goals. Dr. Afolabi will be talking from the Federal Ministry of Health perspective, how the government of Nigeria has sustained service provision amidst the COVID pandemic period. Dr. Afolabi, sir.
Thank you very much, Ogechi. I'd like to recognize my co-presenter and the country director of Amidst International Organization of Nigeria, FION, as well as all stakeholders and implementing partners who are on this webinar today. Then the network of reproductive health journalists, I appreciate your presence at this webinar. I also bring greetings from the principals of the Federal Ministry of Health, from the Honorable Minister of Health, Dr. Sage Hanire, the Minister of State for Health, the Permanent Secretary, as well as the Head of Family Department at the Federal Ministry of Health. I must say that I greatly appreciate this series of webinars by Amidst International, and I want to congratulate you for the achievement that you have been able to document during this challenging period of COVID-19 pandemic. I thank you very much for collaborating with the Federal Ministry of Health on this particular webinar and for asking me to present the perspective of the Federal Ministry of Health on sustaining family planning and sexual and reproductive health services during the COVID pandemic. I am Dr. Kayode Afolabi, the Director and Head of Reproductive Health Division of the Federal Ministry of Health. I'll take you through a few introductory slides before we go to the real issue. Introductory slides on the Reproductive Health Division of the Federal Ministry of Health. That's the next slide. The Reproductive Health Division has the mandate to create an enabling environment and provide leadership and coordination on issues around reproductive health as well as sexual and reproductive health and rights. We operate through 3 branches. Next slide, please. Yes, through 3 branches in the division. We have the safe motherhood, the family planning, and the obstetric fistula elimination program, otherwise referred to as vesicovaginal fistula, or we know generally as BVF. Today, we'll be focusing mainly on family planning and how we have been able to sustain family planning and sexual and reproductive health services during this trying time. Can we go to the next slide, please? If we look at the impact of COVID-19 pandemic on reproductive health and family planning services, we see that it has actually affected so many aspects of our services that have affected the way we live, the way we work. In fact, it is giving us a new normal. And all we are doing is to ensure that we come out of this pandemic stronger and better. So the impact right from the global level exposed the fragility of the supply chain that we have so seriously. Makes us to realize that the supply chain is weak and could be easily affected by any outbreak. For instance, we look right from manufacturing to shipping logistics, as well as clearing even at the different seaports. All these were greatly slowed down or even completely altered. And this gave a lot of players across the globe serious concern. UNFPA went ahead to do an estimate and came up with a figure of 47 million women that may lose access to modern family planning if the situation persists for another 6 months. And the import of this is there could be as high as 7 million unintended pregnancies. Most unintended pregnancies get to be unwanted, undesired, and they have the propensity to lead to unsafe abortion with the sequelae of morbidity and mortality that could follow unsafe abortion. And this also portends a very high risk of high stock out for family planning commodity. You know, UNFPA supply family planning commodity to 46 countries, including Nigeria. And they projected a risk of stock out is very high for long-acting reversible contraceptives, which include implants. All the implants we have, Jadere, Implanon, NXT, and Levoplant, as well as intrauterine contraceptive devices in all these 46 countries. And for injectable ampoules, there could be serious stock out in more than 20 countries, while for condoms, both male and female, there could be serious stock out affecting over 10 countries. This gives a very serious concern to all of us, because like you say, if we do not have commodity, there can't be any program. No commodity, no program. Then the other concern or impact of COVID-19 pandemic response on average family planning service provision in Nigeria, coming back home now, is that initially there was very poor coordination of reproductive health and family planning service provision, because the lockdown and restriction in movements, as well as prohibition on meetings and gatherings, both at national and certain state level, led to some disruption in coordination. And this in turn affects services at all, every care of service delivery, right from tertiary to secondary to the primary Then to make it worse, the state started to experience commodity stockout. Most states, in fact, reported commodity stockout shortly after the first case of coronavirus infection was diagnosed in February 27. You also recollect that we have 3 scheduled national distribution of family planning. The first one for this year was due in March, but this was we were not able to conduct it also because of the effect of coronavirus pandemic. Then our existing protocols and guidelines were lacking in intervention, or our intervention should go during outbreak like we have in COVID-19 pandemic. And on top of all this, we realized that both at the federal level and state level, reproductive health and family planning services were not immediately prioritized. All efforts were directed on containing COVID-19 at different levels. And all these were direct effect of COVID-19 pandemic. We also experienced, next slide please, we also experienced delay in clearing some of our contraceptive commodities from the port, again due to restriction in movement. And of course, when such essential services were allowed to go on, many of the providers at the seaports for clearing such commodities did not comply immediately. So, supposed to do in March, we were only able to do this in May, but we were able to do it successfully, even though there was a delay of about 2 months, as occasioned by the problem of commodity security at the service delivery point also came up because the state did not prioritize last mile distribution to the service delivery point. They also had a lot of challenges around COVID-19 pandemic and interventions focusing mostly on containing this pandemic. And the service providers who are the frontline health worker also were exposed to high potential risk of contracting COVID-19 because initially there was no personal protective equipment, even other basic consumables to be used to support infection prevention and control were not immediately available at service delivery points. So all this culminated in the fact that services sharply declined. So to graphically present all this, how they affect consumption or uptake of commodities, I extracted from the National Family Planning Dashboard mainly 3 commodities, and I studied their trend from January 2020 to April 2020. We had earlier been able to create a lot of demand generation, and most of our family planning method mix are actually on the upward trajectory until January this year. And the point at which we are, January this year through to April, indicates that there are significant fall in uptake of injectable, implants, and IUD. You can also see the trajectory on the screen. Now, to bring this out clearly, we had very high percentage of decline in uptake of injectable, which was as high as 29%. And for implant, the decline was 20%, while IUD was about 14%. And this slide is showing us the impact that COVID-19 has on capacity building for our service provider. I looked through what happened between January and April 2019 and compare with what happened on capacity building throughout the country on family planning services between January and April 2020. While we were able to train in all over 4,000 service providers in 2019, January to April, we were only able to train only 303 nationwide in January to April 2020. And if you also look at distribution of such training where they took place, for January to April 2019, we had training conducted in 21 states, including FCT. Whereas January to April 2020, we were only able to conduct training in 9 states. And it was just only 16 of such training compared to 89 that we had at the same time last year. So to just inform you up front, what we have done on capacity building is to leverage on different online and web-based find this with on-the-job training for hand-on practice. But for the didactic, we leverage on online activities. And that's why we're able to do some training. We are getting improved on this. So let's go to the next slide. What are the impact of COVID-19 with a view to mitigating it? The Honorable Minister of Health, Dr. Sage Anire, granted approval that all the states to sustain their interventions on reproductive, maternal, newborn, child, and adolescent health with nutrition, just as we were doing before the COVID pandemic. And this gave us a lot of boost and created a lot of enabling environment for us at the federal level, and also the communication from the Office of Honorable Minister to Honorable Commissioners at the state, as well as Permanent Secretary, boosted sustenance of family planning services at the state level. And we continue to provide even more enabling environment through articulation of action plan that are necessary for reproductive health and family planning services. This also has been approved for inclusion in the National Response Plan of Action. In addition to this, the Honorable Minister approved the distribution that we conducted in May, and has also given indication that we should proceed to prepare for the next national distribution of family planning commodity. It was quite very challenging to conduct the last distribution, but to secure road paths.
Okay, would you want to consider looking through? Perhaps we.
Hello.
Okay, it's back.
Okay, since it's back. Welcome back, sir.
Hello. Hello.
Hello, we can hear you. Please proceed,
Oh,
sir.
thank you very much. Let me quickly run down. Okay, thank you very much. So we have been leveraging on virtual opportunity to improve on our coordination even during this COVID-19 pandemic response. We've had such coordination meeting with FP coordinators across the states, as well as reproductive health coordinator. And we were able to get feedback from them on their challenges, for them on these challenges. We also had a coordination meeting anchored through the Procurement and Supply Management Subcommittee virtually. This, of course, has supported supply chain greatly. One very important area I want to bring up here is the fact that we are also looking on the issue of maternal health. We appreciate the peculiarity of what it takes to deliver a woman of a pregnant because a lot of infection prevention control interventions, you have to come in here. The baby is also at risk of hypoxia. So unnecessary equipment, respiratory equipment will be needed. And we have given directives to states that every maternity center should have an isolation unit where such will be delivered safely without nosocomial infection to the healthcare provider, as well as to ensure a successful pregnancy outcome. So my slide on conclusion is to quickly highlight. Next slide, Wale. Is to quickly highlight those interventions and some that I could not dilate much on, to bring them up here.
It seems we've lost Dr. Afolabi once more, but I think he's at the very tail end of his presentation. While we wait for him to join, I'll quickly run through this last slide. So basically, the last slide is telling us what the Federal Ministry of Health has done by way of response. It's a summary slide. They've been able to have a national family planning distribution to all states, and they have supported last mile distribution in collaboration with the state government. And this is to ensure that commodities are available and services are also available at the primary place of service uptake. They've been able to do web-based and online in-service training to cushion the effect of the pandemic with regards to capacity building, as well as strengthen community-based family planning programs. And this has ensured that clients receive services and commodities within their immediate communities. Also, the Federal Ministry of Health.
Hello?
It's okay, sir, please proceed.
Yeah, so I just concluded by adding that the federal government of Nigeria provided for 1.22 billion naira in the Appropriation Act of 2020, which is also retained in the revised appropriation bill to support UNFPA for procurement of family planning commodity for the year. Thank you very much. And once again, I apologize for the interruption by the network. I will be willing to respond to questions. I thank you once again for your audience and attention.
Thank you so much, Dr. Afolabi, for taking us through the Federal Ministry of Health's response as regards sustaining family planning services during the COVID period. I'll be opening the chat, the floor right now to take questions, as well as respond to those questions that have been typed into the chat box. So by way of summary, Dr. Afolabi has indicated the various challenges that they encountered: logistic challenge with regards to last mile distribution, commodity being available, as well as guidelines being available to respond immediately the COVID pandemic started. However, they were able to put some of these in place and then secured approval from the Honorable Minister to have last mile distribution of commodities, ensuring that those are available at the primary service delivery points. They also secured approval with passes to ensure that commodities were distributed, and supported some partners with commodities for service provision. And the floor right now is open. Please indicate your hand if you have a question. And while the question is going on, also we'll be putting up the poll with some questions from Dr. Afolabi to gauge how well we have understood his presentation. So about hands are raised right now.
Okay, do you want me to take the first question that I can see from the chat box? There's a comment from Esther who are around PPE supply, but Ronke Atamewalen asked directly, what is the FMOH doing to ensure that PPEs are supplied to health facilities in addition to commodities? And I hope Dr. Afolabi can respond to that.
Okay, yes, thank you very much, Wale, and also thank Ronke for that question. There have been a lot of integrated approach on ensuring that PPE are made available to healthcare providers. Their lives matter to us, and we appreciate the work they are doing in the front line. We all recollect that federal government, through the Presidential Task Force on COVID response, is working also with private sector, as well as international community. So there have been quantification of PPE, and there have been a lot of supply compared to what we had at the beginning when there was virtually none. There were a lot of donations that were brought into the country, and the quantification also took note of what has been supplied and what are needed. Many of the facilities now have PPE. Of course, we have not, we cannot say we have exhausted or we have provided all that are needed in that regard, but government continue to work in collaboration with donors, implementing partners, and the international community in this regard.
Thank you so much, Dr. Folabi.
Just to add also, okay, we have just concluded all arrangements and with our donors and our partners to also 2,500 primary healthcare facilities in the country with PPE materials ranging from infrared thermometers to the disposable masks and aprons for the next 3 months, starting from the month of July. That will be the initial phase as we get more support from our funders to expand this.
Thank you so much, CDF. So right now, Adam has his hand up. Adams, you have been unmuted.
I want to use the opportunity to appreciate Maria Stokes and the Federal Minister of Health for this laudable effort. But despite all of this, with the heightened rate of rape and incest in the country, we have a lot of unwanted pregnancies, and for some going for abortion, and most of them from quacks. Is the federal government doing something to review the abortion law to help reduce maternal mortality coming from unwanted pregnancies? Thank you.
Yeah, okay. Yeah, thank you very much for that question. Yes, a lot is being done. We are also very concerned about this upsurge in the incidence of rape and incest, as well as other gender-based violence in our country. If you recollect, if you mention Violence Against Persons Prohibition Act, it was an act of 2015 by the National Assembly assented to by Mr. President. And this act actually revised the restrictive abortion law we had, but it could only operate in Federal Capital Territory because Earth is on the concurrent list of the Constitution of Federal Republic of Nigeria. So it will take the states, all the states, to domesticate this act in their own states through the state assembly before the act can be enforced. I know there are a number of states that have adopted this act. And what the act provides for, hello, are you there?
Yes, we can hear you.
Can you hear me?
Yeah.
Okay, yes. So what the act provides for on issue of abortion is if abortion results, if pregnancy results from rape or incest, such is allowed to be a legal indication for termination of the pregnancy. But it is more important for us to actually look at ways of preventing rape and incest. And the ministry is working on this, creating awareness on how rape could be prevented. And of course, many of our implementing partners are also providing support to victims of rape and providing information, creating awareness on preventing rape. Thank you.
If I could just come in there to just further buttress Dr. Flavi's point. 8 states for now have domesticated the verb law: Anambra, Ekiti, Ebonyi, Edo, Kaduna, Oyo, Benue, and Enugu. Adamawa is the latest that have passed the law, but the governor is yet to assent to this. I just want to say that please, we should not let down our voice. As I'm happy the journalists are here. This despicable act, this shameful act, this cowardly act must be stamped out. And we must continue to protect our women and girls in every way possible. Thank you.
Thank you, Dr. Folabi, and thank you, C. Jamila Abubakar.
Hello, Shekinah Lawal.
Oh, sorry, my apologies. Please, Shekinah Lawal, go ahead and ask your question.
Dr. Folabi, please. Thank you so much, sir. But from my own monitoring of PHCs around Lagos, I'm Shekinah Lawal in Lagos, member of Reproductive Health Journalist. I discovered that a lot of nurses and midwives, they still do not have access to PPE materials, honestly speaking. And as a result of this, they are not too confident in facing some of the women showing up in our maternity health centers. What is the government doing? Apart from waiting for funders, waiting for donors from outside the country, are we looking inwards, sir? What is the government doing to make sure that we really have enough of this? Thank you very much, sir.
Yeah, thank you too for your question. I think I've mentioned what government is doing from quantification to procurement, and the fact that, of course, we still need to do more so that this could go around. I also expect states to be working on their procurement. I know a number of states have started doing that, but I do not know if they have actually made procurement. To rely on Federal Ministry of Health to procure for every healthcare provider and every facility in the country may be too daunting. So the states also have to be responsive in this regard. Then the other thing we do as part of our leadership role is to ensure that states have reproductive health or FP coordinators as member of the team of their COVID task team response, in such a way that you could also have a voice, we could have voice as stakeholders in reproductive health in whatever decision the state will take in their response to COVID-19, and we'll be able to keep issues of reproductive health in the front burner, including infection prevention and control measures, as well as the PPE. Thank you.
So Yinka Shokunbi is asking, the federal government has a guideline on termination of unwanted pregnancy, which is not widely circulated, just like Lagos has the Safe Engage Act. Does the federal government have plans to escalate the wide circulation of the guideline with the rising profile in sexual violence and declaration of zero tolerance to rape by the NGF?
Okay, so Yinka Shokubi's question is a very interesting one, but I would like to make a correction here. The guideline on termination of pregnancy is not for unwanted pregnancy. It is guideline on termination of pregnancy for therapeutic or legal indication. And we have limited legal indications. It's not every unwanted pregnancy that could actually be terminated by that guideline we refer to. Such termination is only allowed where abortion law is restrictive when there is a risk to the health of the mother by that pregnancy. That's the only legal indication. And there are processes and procedures to it. Now, we are working, in fact, we're working with Maristopes, Population Services International of Nigeria site for Family Health, and other organizations on this. And we have actually disseminated it. Of course, we may need to revisit it because of the upsurge in the incidence of rape. But I think more importantly, where we should all direct our efforts is to support states to adopt the Violence Against Persons Prohibition Act. This will make abortion law to be less restrictive in every state that adopts and domesticate the act.
Thank you. So I think the next question from Emmanuel Ugoji speaks just that last statement you have made. Mr. Ugoji says, VAP is as a result of NGO effort. Even advocacy to states to adopt or domesticate the law is still by NGOs. What else is the Health Ministry doing to ensure that states domesticate or adopt the VAP Act?
In as much as we appreciate our collaboration with all implementing partners, including NGOs, CSOs, and the donor community, I will not agree with what Emmanuel Ugoji said, that everything is done by NGO on VAP Act. I work very closely with IPAS on this Violence Against Persons Prohibition Act. And my other colleagues, director in the Federal Ministry, also are doing the same. We saw the act in a way, it's a law that will enhance maternal health and reproductive health and rights in this country. And as such, we sat down together with our implementing partners and brought out operational standard operating protocol for this act, which was the beginning of where we started to support states. So I want to put on record that the Federal Ministry of Health is providing leadership in conducting advocacy to states. But of course, we can't do it all alone. We need everyone. And that's why I'm calling on our journalists, the media friends, our other implementing partners, that we should continue to keep this informed assistance that the state need to adopt such acts and policy.
All right, thank you so much, Dr. Afolabi.
Hello?
Thank you so much, Dr. Afolabi, for your response. Jamila Abubakar, if you can hear me, please, you have the floor. Immediately after you, will have Dr. Miriam Dagun.
Hello, everybody. Can you hear me?
Yes, please. Hello. Go ahead.
Okay. Thank you very much. Let me first say thank you very much and congratulations to Maristopes and the government of Nigeria for ensuring that services are continued within this period. My question is actually to Maristopes. When he made the initial presentation, I listened to all and I was just wondering whether they witnessed any infection in the service providers with the level of work that was done. And if, because it's something they can also share with others from the states, because if they witness any level of infection, did it impact on the morale of the service providers, the other service providers in providing in providing services to the clients? Thank you very much, and congratulations once again to all.
Jamila, So we've not witnessed any infection. We had one or two scare, if I must be honest, in Gombe, and immediately we reported to NCDC, who within a daytime were able to collect samples. The staff and all those that were with them were put on isolation, and in 2 days' time, the result was out and it was negative. But other than that, we've not had any case yet, but we are not also closing our eyes to the fact that there's still the risks there. And that is why we're constantly supervising, providing people well ahead of time with all the necessary PPE tools, and making sure we check on them on WhatsApp and on call every day. We're tracking to make sure we get first-hand reports every time on this.
Thank you. Effium Ogechi, are you there? Just before you come on, I'd like to just close out on the poll, which we're ending now based on Dr. Afolabi's own. And I'd like to just have Dr. Afolabi restate the correct answers to these poll questions. The first one says UNFPA estimates that 47 million women may lose access to modern contraception if the COVID-19 pandemic situation continues for 6 months and could lead to nearly 7 million unintended pregnancies. 100% of respondents says yes. Dr. Afolabi, is that correct, sir?
Correct.
Okay. Reproductive health and family planning services were interrupted at tertiary, secondary, and primary health facilities due to restrictions on movement to contain the spread of COVID-19, thereby causing commodity stock out. 90% of respondents say yes, and then 10% no. Which is the correct answer, sir?
The 90% is correct. The answer is yes.
Okay, thank you, sir. There was an initial lack of reproductive health and family planning guidelines protocols to be followed in offering services during the COVID-19 pandemic. Is that a yes or no, sir?
Yes, please.
Okay, thank you, sir. Number 4, the Family Health Department secured approval of the Health Minister to communicate to states to sustain information and services on reproductive health and family planning as essential services during COVID-19. 99% of respondents say yes.
Yeah, correct. Yes.
Thank you. And lastly, sir, the Federal Ministry of Health is strengthening community-based family planning program to ensure that family planning clients receive services and commodities within their immediate communities, including in humanitarian settings. Would that also be a yes, sir?
The answer is yes.
Okay, thank you very much. Thank you very much, sir.
My pleasure.
Okay, over to you.
All right, thank you so much, Dr. Afolabi, for taking us through the Federal Ministry of Health perspective in family planning and SRH services during the COVID-19 pandemic. With this, and we'll be wrapping up this particular edition of the webinar series. Just to say that the chat box is open and we'll be here to respond to questions even after now. We want to say a very big thank you to the Federal Ministry of Health for the wonderful collaboration with Amidst to have this webinar hold today. We also thank very much the Reproductive Health Journalists Network of Nigeria for their collaboration with Amidst. Without the support of the health journalists and the Federal Ministry of Health, the success we are seeing today with this webinar would not have been there. We thank especially our country director, Effium Young Effium, for his wonderful support in ensuring that this webinar holds today and for all input. We thank all our participants for taking out time to join us today. Your time is appreciated, and we continue to ask that every one of us on this call lend our voice to ensuring that SRH services remain an essential service and a priority, knowing that pandemic or no pandemic, Reproductive health is an essential need for every man, for every woman. Let's ensure that services continue to be available at our primary healthcare facilities, at our clinics, private or public sector. Thank you, everyone. Thank you to all our speakers. Thank you to all our participants. And thank you to all the team members who have supported this webinar. We say thank you, everyone.